We would like to begin the discussion by asking you, sir, what is TACE and when is it needed?
TACE stands for Arterial Chemo Embolization, or simply we call it Chemo Embolization. It is the standard of care for intermediate stage hepatocellular carcinoma of liver. TACE basically means that a chemotherapeutic medicine and an embolic agent are precisely delivered to the specific area of liver which contains the tumor. This is done via a microcatheter placed in the artery supplying the tumor bed. It is thus a targeted loco-regional therapy which delivers highest concentration of the drug to the affected part of liver, while at the same time sparing the rest of the body. As we just said, TACE is commonly done for hepatocellular carcinoma in the intermediate stage, but it is also used in the metastatic cancers like metastatic colon cancer, breast cancer, carcinoid tumors, and others.
Why is TACE better than conventional treatment?
TACE precisely targets the part of the liver which has got the tumor, and it spares the rest of the liver as well as the rest of the body. This helps us by two ways. It achieves high success rates due to the highest concentration of drug at the target site. And second, it minimizes the systemic side effects because negligible concentration of the drug reach the body. The other advantages of TACE are that it is minimally invasive, it is done under local anesthesia, and the recovery is quick. Besides, in majority of the cases, TACE is a one-time procedure and does not need multiple sessions of treatment as in the conventional chemotherapy. After TACE is done, patients are followed after 1 month when lab investigations and CT scan or a contrast MRI scan is repeated. This is done to assess the results of the treatment. Only in a small percentage of cases there may be residual disease, and for these patients TACE can be repeated.
What is your clinical experience with the results of TACE, and what is the present literature evidence of this procedure?
Presently, as per the medical literature, TACE is recommended for intermediate stage of HCC. TACE is recommended as bridge to liver transplant. TACE helps to keep the tumor size in check and within the Milan criteria while the patient is waiting for an organ. TACE is also recommended as a downstaging modality in patients desirous of liver transplant but are outside Milan criteria. In these patients, TACE helps to downstage the HCC and bring it within Milan criteria so they can become eligible for the transplant. TACE also helps to select the HCC patients with favorable tumor biology for liver transplant. Besides, TACE is also recommended as a combination therapy with RFA, that is radiofrequency ablation, and with microwave ablation, as it has been proven that TACE combined with RFA or TACE combined with microwave ablation has better cure rates. We have extensively used TACE for HCC, and in our experience it performs very well, especially if the patient selection is done properly and the procedure is done very meticulously.
What is the cost-impact analysis of this procedure?
Since TACE is minimally invasive and is done under local anesthesia, recovery is quick, this reduces the hospital stay, and these things reduce the cost. Besides, complication rates are also very low with TACE. This again helps to reduce the cost.
What is your message for general physicians regarding TACE? And what follow-up investigations are required for these patients after this procedure is done?
I would request them to explore the option of TACE for their patients who are suitable for this procedure. I would also suggest them to use contrast-enhanced scans like contrast CT scan or contrast MRI, not just for the diagnostic workup of HCC patients, but also as a follow-up modality, because contrast-enhanced scans are best to assess the treatment response after the TACE.